morning, everyone. My name is Beth Shibley, and this is another Aging Matters in Brevard's Caregiver Conversation. And I'm here this morning with Dr. Agard. Is that how you pronounce your name, Doctor?
Yes, Agard.
Agard, from Clincloud. And today's topic is really, I think it's a really dense topic. It's understanding dementia. And so I'm going to leave you to get right to it as soon as we can, because we got a lot to cover today, Doctor.
Yes, we do. This one is a hefty one. So what we're going to do, I'm going to get into PowerPoint. Whoop. Hang on one second. Let me open up the actual PowerPoint here.
Take your time.
How's everybody doing today?
I'm doing well for a Friday. You can't complain.
All right, here we go. I think it's cooperating now. There we go. Technology, right?
Oh, I know.
Okay, I'm just going to go into a PowerPoint mode. There we go.
Fabulous.
All right, so should we get started?
Sure, sounds good.
All right.
So, first of all, tell me a little bit of, I guess, first I would like you to tell me a little bit about yourself and a little bit about the organization you work for, Clincloud.
Sure. So I am an internal medicine physician, board certified, and I was practicing in the community for a few years. And then I decided to join Clincloud Clinical Research. So basically, we are dedicated purely to doing clinical trials and clinical research, primarily in the Alzheimer's dementia field, but we do other types of clinical research as well for other indications in the body. But our passion is the dementias, and in particular, Alzheimer's disease dementia.
Okay.
So that's really what we do.
That's great. Right.
Yes. Other than that, I don't know if there's anything else or anyone else we needed to wait on, or we can get started.
No, we'll be taping this for and putting it on our for those that we have this all of our caregiver conversations are available on our website and on our Facebook page and on our YouTube channel, so that people can access it whenever it works for them. It's difficult.
Awesome.
It's difficult when you're caregiving.
Like you mentioned, this is a hefty topic. Yes. There's quite a bit for us to get through. Okay. So here we go. Okay. So my name once again is Dr. Malisa Agard, and I'm currently the medical director and investigator over at Clincloud Clinical Trials, and we're located in the Maitland area. Today's presentation is going to be on understanding dementia. And our goal today is going to be to understand the different types, or the difference between the diagnosis of mild cognitive impairment and the diagnosis of dementia. We're also going to hopefully have a better understanding of the symptoms associated with the different types of dementia, and have the ability to better differentiate the disease behind the different types of dementia, have a little more knowledge of the workup needed to help with dementia diagnosis, and knowledge of the available that are out there for dementia. So I always like to start by giving just a overall idea of what the different types of dementias are, or memory disorders. We have mild cognitive impairment, which some might hear their doctor mention once they start saying, I'm becoming forgetful. Then we have what we call the neurodegenerative dementias, and that's going to be Alzheimer's disease, Parkinson disease dementia, dementia with Lewy bodies, and the frontotemporal dementias. Then we also have the non-neurodegenerative dementias, and that's going to be vascular dementia, normal pressure hydrocephalus, chronic traumatic encephalopathy, and the rapidly progressive dementias. Oh. All right. And so I always like to start out this this presentation with first explaining, well, what is memory, right? Before we can know how it's affected, I think it's important we understand what it is. So memory is basically our ability to encode, store, retain, and recall information as well as experiences that's happening throughout our life. So whether that be a simple conversation that's happening between family members or something that's happening between you and your doctor, or watching a movie or reading a book, anything that you do, you have to take in that information. You have to be able to encode that information in order to understand it, to store it, and then bring it back when you need to bring it back. As we age, those little cells that talk to each other, the connections between them can tend to become weak. And when that becomes weak, then we also have some loss of brain tissue, we call it. And we call it atrophy. So anyone that might have gotten some brain imaging, or your loved one has gotten some brain imaging, you might see where they say, oh, you know, normal brain tissue loss for age, or involutions consistent with age, or atrophy consistent with age. That's the normal changes that we expect to see as we age. However, loss of brain tissue can also happen from neurodegenerative diseases. And those are the diseases that we're really going to focus in on today, because we want to kind of have a better idea of what does that mean, right? We want to know, well, if our loved one's having these symptoms, is it because they have Alzheimer's, or is it something else? As physicians, we're going to do our best to differentiate between those, but at times the picture can be difficult, and we need family members to know what it is to tell us to maybe help us differentiate better. Also to advocate for their loved one. So what is cognitive impairment? So this is another word that gets thrown around a lot when you go to the doctor, or you're seeing a neurologist or a specialist or a memory physician. Cognitive impairment is a progressive loss of cognitive function, meaning your ability to process and think in at least one of the major areas. So we consider the categories of cognitive function to be memory, language, executive function, which is typically going to be judgment, planning, reasoning, and insight. Also visuospatial function, which space between things, navigating, you know, when you're driving and knowing, you know, where you need to go to turn, those sorts of things. And it could also mean just misplacing items. Have behavior that we're having the disease affect us. A lot of the times we'll see a lot of we don't have to think about when there isn't something affecting it. But when there is something affecting it, then we have to pinpoint which one of these are being affected. So the next thing we're going to talk about is, what is this word dementia? I feel like it gets thrown around a lot. And I feel like when we use the word dementia, we need to think of the first thing, right? Time that with patient of mine, they, you know, they're saddened, they think, oh, this is the end. But I think it's very important to understand what dementia is. So dementia is really a general term that we use to describe progressive cognitive impairment. And that usually involves at least one of those cognitive functions that are own, but they may become forgetful. We more think of mild cognitive impairment. When they start to depend on someone else to help them because they're losing some of that independent function, that's when we start to think of more dementia. So there are different stages of dementia. Here we're going to do the general, early, moderate, and severe. So for the early stages, I just like to kind of differentiate. So you're going to be functioning pretty independently, meaning you're doing everything on your own. You may have some problems with concentration, some challenges in performing tasks, some trouble remembering new information or processing things. You might have a little more trouble getting tasks done because you have to really think about it more.
Mhm.
As you move into more the moderate stage, then there's more confusion that's happening. That can be with words. You might see some personality changes. Maybe the person starts to become more withdrawn because they're afraid of someone figuring out they can't remember things, or they can't think of a word, or they're getting lost in a conversation or even a sentence, really. In addition, the forgetfulness, which I've already mentioned, and you also can start to have some changes in sleep patterns. Then if we start to transition over to the severe stage, this is where really you require 24-hour supervision or care or assistance. In the moderate stages, you might need your family members to start helping you with things like the financials, making sure your meds are laid out and you take them, maybe driving you to the store because you can't go by yourself anymore. You might get lost, or you forget what you go in there for, or you get lost just wandering, in the neighborhood. So you need some supervision. When you get into more this.
No, Doc, I have a question. I know I don't want to nail you down to anything specific, but in general, the progression of dementia, is there a wide range between with individuals? I mean, can some folks progress from one stage to another in a matter of years, or for other people might it take decades, or sometimes is it quicker? Yes. I'm just kind of looking for an average, if there is anything like that, average amount of time where you might be looking for these stages to progress. Do you have?
So I would love to tell you that there is a nice carved out time frame for each stage, or when a person will go from mild cognitive impairment to dementia of any stage. Unfortunately, there isn't. Every person is different.
Right. So, welcome to science.
Yes, you may have a patient that goes from mild cognitive impairment to a severe stage of dementia in 2 years. You may have a patient that it takes 10 years. You may have a patient that, they may have the early signs of dementia, but they don't progress to even the moderate or the severe in 15 years. So it's very different for everyone. And the factors I think that's important for a family member to keep in consideration, it's going to come down to how much involvement is there from the family? Are they isolated? Do they still go out and do things at clubs and with friends? And, do they engage in conversation regularly? Do they do things to stimulate their brain? How are their comorbidities like hypertension, diabetes, hypercholesterolemia? Are those well controlled? Do they exercise, go walking? I don't mean like running marathons, but at least go out and have like a 15-minute walk every day. So how are they taking care of themselves, and how are you incorporated into that? I think that's the important factor for a lot of people in how they will progress. A person that is at home all day by themselves, not really interacting with anyone, not stimulating their mind, might progress much more rapidly and over, let's say, like a 1 to 2 year mark, from mild cognitive impairment or early stage to severe stage. Whereas a person that is constantly interacting with their family, maybe they're volunteering in the community, they eat well, they exercise, they're always following up with their doctor, for them, it may take 5 to 10 years because they're doing things to keep their mind going.
So there are things that we can do. I mean, and that's one of the things that's changed I think with dementia over the decades. My grandfather was diagnosed with it 40 years ago. And back then, almost a half a century ago, it was sort of, well, there's not much you can do about it. Here we go. And I think, in no surprise, in 40 years, we're learning so much about how much we can impact this horrible disease.
Yeah, definitely. Now, with that said, I do want to say that people can do all of those things. And if it's a certain type of dementia, they can still progress very rapidly.
Absolutely.
But that's usually what we promote: healthy living, brain stimulation. And I think what we've seen is that people who are kind of more going down that path, it tends to be a slightly slower progression depending on which one they have.
Yes.
Okay. So back to the severe stage. In the severe stage, we usually require, well, the patient requires constant supervision. They really can't do much for themselves at this point. Even activities of daily living, which is like bathing, dressing, feeding themselves, preparing their meals, they're not able to do those things anymore. So now they're requiring someone to help them with that. There may also be some severe behavioral changes, wandering, unsafe behavior. So you always need to have someone watching that person or being around that person. They're unable to respond to environment or hold a conversation. So if something were to happen around them, they can't process it correctly. They can't make the right judgments in what to do. So that's why, once again, you need someone that's there constantly. They also have changes in the physical abilities. Now, that can be anywhere to where they're severely slowed down to where they can't walk anymore. So that can range as well, depending on what's happening with the patient and how much damage is in the brain and where is that damage, right? And they also will be unaware of any recent experiences. So it gets to the point where that short-term recall, short-term memory storage is completely gone. So if they remember things, it's going to be things from a long time ago. It's not going to be any new memories or new things. Because they can't process it, they can't encode it, they can't store it, they can't recall it. All of those things that we need for memory to work becomes affected. Okay. So I like to go over this slide because I get this question a lot. How do we screen for dementia? What do we need to do? What age? Those are the questions I usually get. Even though it's been almost half a decade, or half a century, I should say, we still don't have a nice, clear-cut, this is what everybody should do. Currently, we have no accepted standard for dementia screening. The U.S. Preventative Service Task Force, which is what a lot of, physicians will go on when it comes to things like, when do you get a mammogram? When do you get a colonoscopy? When should we start checking your blood pressure? When do we need to check your heart? They come up with all of these guidelines, and they don't have any specific screening that they endorse at the moment. However, the Association of Gerontology and Geriatrics do recommend some form of cognitive screening annually in patients 70 and older currently. Medicare promotes everyone 65 and above having some sort of cognitive assessment at their annual physical, whether that be subjective, where the patient's telling you, oh, I'm starting to feel a little bit forgetful, or it's objective, where you do a quick 5-word test or something with them. Some cognitive assessments that can be done very quickly. Some are, 2 minutes, 5 minutes, and some can be 20 minutes, 25 minutes. And that would be the MoCA, MMSE. There's the Ascertain Dementia 8 questionnaire. So with that one, they are going to ask some things about activities of daily living. So they're trying to have a quick assessment of you overall. Mini cog, and then the 5-word memory test, where basically I tell you 5 words, you repeat it a couple of times, I come back to it after a little time has gone by and see if you remember those words. So it just depends on what your physician is able to do in the time that they have. So now we're going to get into each individual disease, basically. I like to start out with mild cognitive impairment because, in the perfect world, this is where we're going to start our journey. You're going to come in, a patient might say, I'm becoming forgetful. We do a quick test. We see that there's some memory difficulty that's happening. It's very early. So we'll say, okay, mild cognitive impairment. The symptoms usually of just the cognitive decline, like I mentioned, but they're able to do everything. They are functioning independently. A lot of the times these people are still working and they're not having any problems doing their job. It's just like every now and then they may forget an appointment, may forget a word, may not remember a conversation or something of the sort, right? And usually you think, oh, I'm just distracted, or oh, maybe I'm just getting older, and that's what it is. But it's really that maybe it's the early signs of something else is happening. They're usually subjective reported that decline. So it's not usually going to be family members coming out of the woodworks to say something's wrong with mom and dad, or something's wrong with my sister, or something's wrong with my friend. This is usually going to be the person reporting it. Also, I think it's important to just keep in mind the annual risk of this person who is in mild cognitive impairment to progress to, let's say, an early stage of dementia is about 5 to 15%. And it's going to come down to how do they live their life? What else is going on with them medically? And what do they do once they find out this diagnosis, right? Some people will say, oh, I'm not going to do anything. Some people may start a memory med. Some people may be like, I want to seek out a clinical trial that can maybe help this from going any further, that sort of thing. So it just comes down to what does that person do? So next we're going to get into, well, what are the evaluations once we have this diagnosis, right? Or your physician suspects this diagnosis. And usually it's going to be cognitive assessments, similar to the ones I just mentioned, but there can be more in-depth ones that you will get done through either, your primary care physician, through a research center, or through a neuropsychologist, or through a neurologist. Or if your primary care physician notices this and want to refer you to something like a memory clinic, that can also be a place that you would get that done. A neurological exam is really looking for other things going on with the body that could be indicating to us, like, well, maybe this is something else happening causing some of this memory decline. We also evaluate for depression because mood is a very big thing, and very much so connected with how motivated we are to process and encode and store things and remember things. If we are very severely depressed, unfortunately, our motivation to do anything, learn anything, keep anything in our brain is incredibly low. So it can actually hinder us from just performing normal cognitive functions like we would want to. And sometimes for those patients, you fix the depression and you help the memory. Sleep disorder, also another big one, uncontrolled sleep apnea. That is a big one that I see a lot with the patient population. Let's say, this has been going on for years. You haven't been getting good oxygen to your brain when you sleep. I think you would assume at that point, you will not be processing things as well as you should.
Well, in addition, am I correct, doctor, that from what I've heard, a lot of how our neurology and our brain repairs itself happens at night.
Yeah.
So, that's when we cleanse, that's when we process, that's when we encode. So my husband is, God bless him, has been on a CPAP for years. And when he did his sleep study, there was interrupted sleep, dozens and dozens of times an hour. That he was really struggling with. And it was, well, no wonder why you're dealing with all this other stuff. So that's
So even with that, you think of the fact there's one, and the oxygen's not going to your brain. So that's going to affect things. And then two, you're actually, with sleep apnea, you stop breathing for seconds at a time.
Absolutely.
And then usually you're jolted awake in a sense because you restart your breathing. Right. And so a person doesn't get good, deep sleep to process, and then they're tired all throughout the day. I don't know about you, but the more tired I get, the processing of my own self and things going on around me slows down because you're tired. Your brain is just like, listen, we're going to use the energy in the most important areas that we need to, right? So fixing those sorts of things is going to be really, really important in better assessing, is this truly a memory disorder, or is this something that's just masking it, right? And pretending to be. So there's that. And then substance abuse, things like alcoholism, things like a lot of the different types of just recreational drugs can affect some of our memory long-term. Assessing family history of dementia. So if, you were to come in and say, I'm forgetful, and my mother, my father, my grandmother, their aunt, this whole family tree of everyone having memory problems and dementia or Alzheimer's disease, then that tends to move a little bit higher on my list, that maybe we're dealing more with an actual neurocognitive type of disease, and we're not masking something else. Right? So the other evaluation would be an MRI of your brain. We're looking to rule out anything happening in the brain. Are there significant strokes? Is there a mass? Are the fluid circulation areas in your brain okay? So all of those things we're going to find out with an MRI. Then there's something called a PET scan. Usually in the community, we can get it, what we call an FDG PET. So basically that's looking at like sugar uptake in your brain, and what does it do with that sugar? Is it all lit up and metabolic and doing things and processing things, or is it all kind of just slowed down and it's not doing anything? Then there's also tracer specific PET scans. Usually these you can get through clinical research. And that's going to be things like an amyloid PET scan, which targets just amyloid plaques, or a tau PET scan, which is just going to target tau tangles. In addition, we can do blood tests. We want to rule out things like vitamin B12 deficiency, vitamin D deficiency, uncontrolled thyroid diseases, because all of these things, if they are happening, can also cause us to have some difficulty with memory processing. So we always want to replenish those and get them stable so we can make sure, is there something else that's, once again, causing us to have memory difficulty? And then there's something called a SPECT scan. So basically it's a perfusion scan of your brain. They're looking to see, are you getting good perfusion and low activity, or is there difficulties with the arteries that's coming to your brain or within your brain that's not giving you enough oxygen and blood flow? And then there's something called the CSF, or the cerebrospinal fluid. And basically that is just the fluid that coats our spinal cord, goes up to our brain, flows through our brain, and just keeps everything nice and cushioned, and also cleanses and takes out the bad stuff and takes it to other areas of the body. So we can do all these assessments to just have a better picture of what's happening. Treatment-wise for mild cognitive impairment, there's no medication treatment for prevention of it getting worse, right? If you have mild cognitive impairment, sometimes they'll give you one of the memory medications that I'll be going over a little bit later, as we talk about things like Alzheimer's disease. But lifestyle modifications and brain stimulation, that's going to be the big things, and continuing to just monitor your symptoms. This is when you have to be your biggest advocate. If you think to yourself, I'm getting worse, I believe, and it's been 3 months since the last time you were assessed, get assessed again, right? If you're like, oh, I'm going to wait till next year, things might be significantly worse, because now you've given a lot more time for things to progress. And then treating reversible diseases or findings. So like if it's a B12 deficiency, replace the B12. If your thyroid is not functioning well, let's fix that, and then reassess and see if things get better. So now we're going to talk about Alzheimer's disease dementia. This is really the most common type of dementia. It also happens to be a neurodegenerative type of dementia. So Alzheimer's disease dementia is caused, they think, by proteins called beta amyloid that accumulate in the brain and form these plaques, like scabs on your brain. And they also believe something called a tau tangle, which are all these little hair-like looking things that's inside of the cell. And what these tau tangles do, prevent nutrients from coming in appropriately and prevent information from going out appropriately. So the cell almost dies off because it's not going to communicate well, and it can't get the nutrients it needs in order to survive. The tau tangle, the beta amyloid plaque that you see out here, these little things here are called synapses. And these are how these cells talk to each other. So they'll imagine another cell right next to it, and this is going to communicate with that cell. But there's this big old scab here that we call the beta amyloid plaque that's going to prevent that information from going from cell to cell, from synapses to synapses. This is going to cause a lot of inflammation, and eventually it's going to cause the tissue to break down and scar up. So the cell will die, the tissue in the area will die off, and that's where we start to see loss of brain tissue. And these scans over here are showing you, you see these big spaces that are happening in between. That's actually what happens when you start to lose all that good brain tissue, and we call it atrophy. You start to have really big spaces between what we call the sulci and the gyri. And when we start to see this, we think, well, is this normal for age? Because naturally when we age, we lose some of it. Or is it abnormal for age? If this is a 60-year-old, that would be completely abnormal for age. Even someone who is 80, 90, if they're very active and still involved, this would be probably still abnormal for age. But if it's someone that's not really doing a whole lot, maybe this could be normal for someone who's in the last couple of decades of their life.
Okay, so here's another question I have, Dr.
Sure.
My mom, and you know, I mean, we've all been dealing with this pandemic, and you know, her activities. I mean, she went, you know, in 2019, her activities. She was out. She was playing euchre. She was out. She was playing mahjong. She was going to do different things with her friends. She was out, and she's still in, you know, living on her own and active and doing these things, but lately she's been saying, God, you know, I just feel like I'm just not connecting anywhere, you know, and I hear her concerns about these sort of things. And I'm wondering whether or not you're seeing an uptick in concerns with folks because of their isolation, because their worlds are smaller.
Oh, yes. Oh, yes. There's an uptick in people saying those types of things. There's an uptick in mental health needs.
Oh, absolutely.
There's also an uptick in people who are starting to progress more rapidly because they're just isolated,
right?
You know,
right.
And we're not able to do all those things that we were able to do before. So we're really pushing for things like Zoom bingo, maybe if possible, a Zoom, some sort of card game, which is kind of difficult when, you know, everyone's got their own deck, but just pushing for things that we can do in the platforms that we have right now to make sure that people stay engaged as best as we can.
Well, thank you. I'm happy to report that my mom got her second shot a few weeks ago. Yay. And I think she had her first group of friends. She had her first group of three friends came over. They're all vaccinated. And I think they played euchre last night. So
nice. So that's the hope, right? Everyone gets vaccinated and we can start to get back to normal. Right. I just hope that everyone just, you know, follows that trend so that we can all get there. Because if there's, you know, we don't have enough immunity in the community, then hey, we're going to still be doing what we're doing right now for longer.
We're all tired of it.
Yes. But one other thing I wanted to point out with this second MRI over on this side is you see in this particular area here, it looks like it's lost more brain tissue than, let's say, you know, other little areas like in the front. And this is called the temporal area. And in Alzheimer's disease, this is one area that we tend to focus in on a lot in the beginning stages for a diagnosis, because it tends to affect this area a lot. And in particular, in a place called the Hippocampi. And there'll be another image that I show you in a different type of angle where you can see a little better what that looks like. But important things to keep in mind, apart from the brain volume loss, is going to be that these deposits of beta amyloid plaques and tau tangles can happen as early as 15 to 20 years prior to symptoms really starting to show themselves. So this is why I always promote to people, if you have a strong family history or any family history, please just get a baseline early, because you can catch something before it really starts to get into something bad. In addition, knowing that this can be starting to happen 20 years before you really feel like, hey, maybe this forgetfulness is more than just me getting older. You can have a baseline every year. And this can start as early as in your 40s. All you have to do is have a conversation with your doctor and say, I have a family history of Alzheimer's disease. I would like to just, have a nice little baseline starting early, and we'll do it once a year. Now, I understand some people are a little bit scared of what that might show and what that might mean if you do find, oh my gosh, there's something happening and I'm still 45, let's say. Then you might, that might be a very emotional, that might be very nerve-wracking for some, and that might change the way in which they live their lives. But at the same time, I challenge them to say, well, you may think your life is changing now. Imagine what it will be like, 20 years from now, if you don't do something starting now. And if you want 20 years from now to be a more positive picture, do all you can now while you still can, right? Because once the damage happens, once this tissue is gone, unfortunately, we can't regenerate that yet. Maybe 20 years from now, it will be different and we'll have incredible more technology and stem cells and all of those wonderful things. But as of right now, brain tissue is not something that we can regenerate. So onset can be, if it's an early onset Alzheimer's disease, will be in their 40s. I've seen as early as 45 personally, and older. Gradual, unless the onset is younger. So usually it's over the years, you start to become forgetful, a little more forgetful, starting to have things be affected in your day-to-day living. And that's how usually it'll progress. It's usually not a very rapid thing.
Right.
So risk factors, unfortunately, the number one risk factor is age, something that none of us have control over. We're all going to age, hopefully. Yes. And as you get older than 65, your risk tends to start going up even more, with about 32% of cases being in adults over 85. Genes, also a big thing. The ApoE gene is the one we usually think of. There's actually ApoE2, 3, and 4 that we really focus in on, but 4 is the big one that we talk about the most. So if you have the gene, doesn't 100% say that you're going to have Alzheimer's disease, but it just places you at a higher risk. Increased risk if a parent, a sibling, or a child has the disease, and also being a female puts you at a higher risk as well. And if you have uncontrolled things like diabetes, obesity, hypertension, cardiovascular disease, strokes, you use tobacco, which puts you at a higher risk for cardiovascular and cerebrovascular disease, all of those things are going to increase your risk as well. So some of the symptoms that you can look out for, right? It will be that gradual worsening I talked about of memory, forgetfulness. You may start repeating questions, repeating stories to people. You may have some difficulties with word finding. You're having a sentence and then you're like, oh, I can't think of the word. It's on the tip of my tongue, but it just won't come to me. Those start to happen more frequently. And you may have some problems with what we call the executive functions. So that's reasoning through a problem, making the right judgment calls in situations, planning things. You got to write everything down. If you don't have your calendar, you don't know what's going on. Those sorts of things start to develop. Also, problems with navigation, meaning knowing where to go, whether that be driving or walking. So that's a big one. That's usually also one of the first things. Someone will have an episode where they're driving in the car. It's a routine drive, going to the grocery store, and they have to pull over because they can't remember, how do I get there? And it could be 2 minutes up the road, right? Behavior and mood changes. So signs of depression, signs of anxiety. Those are both two things. Becoming more isolated, not being as conversational. All of those types of changes you can look out for. Hallucinations in Alzheimer's disease is very rare. And it's usually when someone gets to more the severe stage of dementia. So if from the get-go you're seeing hallucinations and delusions, my first instinct is not going to be Alzheimer's disease. Okay. I would be more looking at the other types of dementia.
Right.
Also, you might see some motor and gait changes, meaning slower gait, more difficulty with balance, more difficulty with walking, more rigid. But those things are going to happen once again in more the moderate to severe stages. It's not going to be in early stages. So evaluation for Alzheimer's disease is very similar to evaluation when you come in and you say, I'm being forgetful. So the MRI of the brain, we're looking for that decreased volume in the hippocampi that I mentioned earlier. And this is the image I'm talking about. This whole area here is what we call your temporal area. So it's these areas of your face, right? And it has a very big influence on our processing of memories, our processing of just information. Also, as we get to the outer edges, we can start talking about things like language. But this here is what we call the hippocampi area. And you can see there's so much space in this area that should be filled up with brain tissue. So in this particular patient, it's showing you that, hey, they've lost a lot of brain volume in this area. Now this looks like a little worm opposed to looking like a nice full brain tissue. The PET scans that I talked about, the same, you can do the FDG PET, where you would see decreased metabolic activity diffusely. So the whole brain is just kind of slowed down. And then the tracer specific PET scans would be the amyloid PET scan and the tau PET scan. So the tracer is just going to tag either amyloid or it's just going to tag the tau proteins. And it lights up and then we see, okay, they have this amount or they have of amyloid or they have this amount of tau. Then the SPECT scan, like I mentioned, perfusion to the brain. And then the CSF, we're going to be looking, to rule out anything else, infection, too much volume. Is there like cancer cells that we're seeing in that? Is there other rare diseases, we'll say, that can be there? Or is there beta amyloid in it? Is there tau in it? We can actually find these proteins within the CSF. Blood tests is the same blood test that I talked about during the mild cognitive evaluation. However, they're now trying to develop a blood test where they'll be able to identify amyloid. So instead of having to be more invasive, hopefully if all goes well and it works very well, we can just do a blood test and see if the levels are high. And then there's cognitive assessments, like we mentioned, and the neurological exam, that's the same. So treatment-wise, we have what we call the acetylcholine esterase inhibitors. So it's a neurotransmitter, meaning it's a protein or like a hormone in our brain, I think is a better way to put it, that helps us with the processing and allowing your synapses to talk to each other and transfer that information and do all the things necessary for a memory. These particular medicines prevent the breakdown of that hormone so that it can't, so what needs to happen will happen. It does not reverse any amyloid protein deposition. It does not stop amyloid protein deposition. So therefore, we just call it a symptomatic treatment. It is not a disease modifying treatment. What that means also is that it's not going to stop any progression of the disease. And that's donepezil or Aricept, rivastigmine, galantamine, or they do combos of these. Okay. Memantine is another one. That one we usually do when a patient gets to more the moderate stage, in hopes of helping to boost whatever we can in those normal brain tissue and keep those synapses talking to each other. But it is also just a symptomatic treatment. It is not disease modifying. Okay. Treatment of risk factors or contributing factors. So we're talking about, thyroid disease, any infections, vitamin deficiencies. We want to take care of all of those to have our best brain function. And then investigational drugs. When I say that, that's where the clinical trials would come into play. And those medications, usually right now, the big focus is on what we call MABs, or they're basically monoclonal antibodies. So it's these drugs are antibodies, are like the little soldiers in your body that fight off infection, but we're generating them that they can go and just sit on a beta amyloid plaque and indicate to your body like, hey, this is here. Let's do something about it, right? And so it's basically just flagging the bad guys. And the one that is the most popular or best heard of right now is Adukanamab, and it's from a company named Biogen. And it's actually right now in the process of going to the FDA in hopes of it becoming or being approved for treatment of patients with Alzheimer's disease.
So this would actually be a treatment drug?
This would be a disease-modifying drug.
Wow, that's huge, doctor.
Yes, yes. And our hope, fingers crossed, the FDA will look at all the data that's been collected and see the outcomes of the patient and think that it is significant and that this drug will be more beneficial to people and therefore allow it to be on the market. But this is not the only one that's out there. There are a few other MABs, just for it to be short, that are also under investigation, that are in the later stages just before going to FDA. So there is hope that maybe in the next 2 to 5 years, something will be on the market. There's hope.
Huge.
Yes. And we're all incredibly excited about that. And I really do hope that it does well. But if you reach out to a local clinical research center, they will be able to let you know if there are any treatments that are disease modifying that might be possible. Another area of investigation is decreasing inflammation in the brain. And by decreasing inflammation, will that cause less damage, less loss of brain tissue, and therefore decrease progression of Alzheimer's disease? So we're trying to tackle it from different avenues in the event that, let's say, the MAB is not the end all, right? With all the drugs that we have for symptoms, we should have different drugs that we can use maybe in different stages for patients who are having Alzheimer's. So the future, I think, is very hopeful. Now, like we talked about earlier, one of the best things that we can do to help our brain is going to be brain stimulation and exercise, as well as taking care of our bodies. So brain stimulation, solitaire, all the different word games, word find games, Candy Crush, all of these types of things allows you to continue to stimulate your brain because you've got to understand what's happening in them in order to play the game. So that's something that we can use our wonderful technology that we have. Everyone's got a smartphone, tablet, something that they can play these types of games on. A good old jigsaw puzzle, that is actually wonderful to help stimulate your brain, that you have to look at a picture and be able to put that picture back together from all these tiny little pieces. Exercise. I always promote exercise. I think it's very important for everybody. And, you know, even if it's just walking 5 minutes away from your house, turn around and walking 5 minutes back, it's helping your muscles, it's stimulating your mind, it's creating endorphins, and it helps you overall.
Right.
Playing games with people. We talked about euchre and we talked about mahjong. Chess is a great one. So just getting together and playing games with people is actually wonderful for our brains.
And words with friends for people who have to be, who still have to be socially distant.
Yes, words with friends is a great one, actually, because you also have to think a lot to do that one. I used to love that one. I played it all the time. And there's one called, I think it's called Wordscapes, where they give you letters and you have to create the word from it. And it's like a crossword, and, you know, depending, you have to create words of different sizes. So I think that one's also a great one. Then diet. We kind of tend to promote more of a Mediterranean type diet with patients who have memory disorder. It gives you fruit, vegetables, you know, nuts if you can eat it, kind of a low carb, lean proteins, all of these things to just help promote a really healthy body. And that's in the good fatty oils like olive oils, omega-3, all of those types of things to really help promote keeping the brain as healthy as possible. And then engagement with people, family, friends, all of those types of things. I know we're a little bit more socially distanced now, but like a Zoom family conference, everybody's just doing their thing at home, but everybody's together in a sense. We can always do that for now until everyone's a little more vaccinated. Next, we're going to move on to Parkinson's disease dementia. Now, this one is it's different from Alzheimer's, but similar in it starts to affect all your cognitive functions over time, and that's why it falls into the category of dementia. But with Parkinson's disease, what happens is you have a gradual loss of something called the dopamine-producing nerve cells. And this is in a specific area of the brain called the substantia nigra. And what happens is we start to lose those cells. So we start to have a lot of movement issues. Then there's deposition of what we call Lewy bodies or alpha-synuclein. And when that happens and that deposits, it causes further damage of the nerve cells, right? And that's, alpha-synuclein. And the onset of it is basically around anywhere younger than 65 is generally where we start to see onset of the movement symptoms. Now, with Parkinson's disease dementia, you're going to usually have those movement symptoms for many, many, many years that might progress. And then you start to develop some of the cognitive issues. It's not going to be movement issues within a short period of time. You start having memory issues and it all happens together. That's a different type of disease if you start to see that. The risk factors for this is aging. Once again, something we have no control over. It happens to pretty much all of us. The other one, there are, I think it's about 11 to 16 genes that they've looked at that can result in or have some sort of role in developing Parkinson's disease. Some are what we call autosomal dominant, meaning that we only need to get one of those genes from mom or dad. And some are what we call recessive, which means we have to get both of those bad genes from mom and dad. Okay. And then, almost we have to say like the perfect storm happens to trigger the genes to lead to the disease. And then we have family history. So if we start to see motor symptoms and we were to find a gene per se, and we are interviewing you and you say, yeah, my dad had Parkinson's disease, it kind of jumps up a little higher on the list. Exposure to things like pesticides and other environmental agents can increase the risk, they believe. Also heavy metals. But the exact correlation, we're still kind of working out there.
Yeah, speaking of it, my dad actually had Parkinson's and Lewy body. And he had spent many years working with heavy metals, working with lead, working with, in a confined environment. And so, looking back on it now, we're kind of scratching our head and wondering if that didn't have something to do with it,
It possibly could have. Possibly could have. The other thing, let's talk a little bit more about specific symptoms. So the patients tend to have what we call a resting tremor. So whenever they're at rest, you may see like their hands are doing something. Usually we say it's the pill rolling tremor. So they do something similar to this, but they don't even realize they're doing it. Yep, it might just be of the head. It might be of the whole hand. It might be of a leg. But typically we see the pill rolling tremor. They also have some gait changes. So typically it's a stooped over, they start to become very stooped over. Shuffling gaits, so short kind of shuffling steps. They also have less facial expression. We call it a masked faces. So, they're not overly excited. They're not overly sad. It's very difficult to read. Also, depression is a big thing that tends to happen. And depending on how the progression goes, you can also develop some agitation and maybe a little of aggression. Small handwriting, typically due to the tremor, when they're trying to write, it's very difficult and their handwriting becomes smaller and smaller and smaller. They have just basically any problems with any fine motor movement or really gross movements. slowing of movements in general, they become more rigid, which I'm sure you already know all of this. And then also problems with what we call the autonomic nervous system. So things like blood pressure, swallowing, all of those types of things can become affected. Normal breathing as the disease progresses. So cardinal signs, which, since we're kind of trying to be able to differentiate things, so you're going to look for a tremor at rest. You're going to look for what we call bradykinesia, or slowed body movements, becoming more rigid in their movements, rigidity, and the gait balance changes. So that shuffling gait and difficulty with, you get to a place and you need to turn around, they have to do it very slowly because their balance also starts to get off and they can fall very easily. So the evaluation, very similar to the others, but the extra ones that we throw in for Parkinson's disease is something called a DAP scan, or a DAT scan, sorry. And that is checking for the dopamine cells. So we do that particular scan, and if we see that there's a deficit in those particular cells in the area that I mentioned, then we say, okay, this is most likely an Parkinson's disease picture. We also still do the same cognitive testing when patients start to develop cognitive issues or memory issues. Now, I just once again want to reiterate, this usually happens years after you have started to develop these motor symptoms. So it's not going to coincide with the onset of the motor symptoms. Gait assessments, because they do have such a difficulty with shuffling gait and balance and those sorts of things, we try to see what can be done in order to help with that. And then depression and anxiety screening, because like I mentioned, depression is a big thing that we see with Parkinson's disease. Anxiety as well, because if the falls happen or, you wander, you get lost, all those things are very anxiety provoking. So it's just, something we try to keep an eye on, because we want to make sure that loss of life is not because we missed being able to treat this part. So treatment wise, the big one is we talk about dopamine medications. So people might have heard of like carbidopa, levodopa, all of these medicines that are trying to replace the dopamine and keep the dopamine around so that we can have enough of it there to interact with receptors and create as normal of movements as we can. Medication also for the non-movement symptoms like depression, anxiety. If they're having memory difficulty, some of the meds that I talked about that we can do for symptomatic memory issues. So like Aricept or donepezil or rivastigmine or one of those. Daily exercise can also improve their gait and their balance. Usually a lot of these patients, eventually there is, now some physical therapy programs that deal just with Parkinson's disease patients. And they really work with them to get them to move better. And I have had many patients that have been involved in those, and they do really, really well with being able to get around because of it. And when they don't do it, I see a very different picture. So those programs are really great. And then deep brain stimulation is something that we explore later on. A lot of the times if patients are starting to have difficulties with swallowing, breathing, those sorts of things, then we start to get into more of the deep brain stimulation. Now let's talk about dementia with Lewy bodies. Now, dementia with Lewy bodies is the second most common type of neurodegenerative dementia, not dementia overall, just neurodegenerative dementias. The cause of these is deposition of those Lewy bodies that we kind of just talked about with Parkinson's disease, but you can also have findings of Alzheimer's disease. So you can also see amyloid plaques, you can also see tau tangles, but you will see the Lewy bodies as well. In addition, they usually will have motor symptoms earlier, and the onset of motor symptoms to memory symptoms will be very rapid. So Alzheimer's disease is very gradual, very slow, usually, right? Dementia with Lewy bodies, it's like a night and day kind of thing that happens. So symptoms and onset are all very similar to Alzheimer's disease, but it normally progresses more rapidly. And I made sure to put here, dementia and motor symptoms usually develop within 1 to 2 years of each other. Okay, so if you see this type of picture and someone's telling you Alzheimer's disease, I want you to challenge them and say, you sure?
Right.
Of course, it could be an early onset rapid Alzheimer's disease type, but most likely we need to look for something else. Risk factors are the exact same as Parkinson's disease. And age, of course, I always put that there because I want people to continue to think, hey, as I age, I'm at risk for any of these, right? So that's why it's so important to follow up with your brain health. So specific symptoms. So we tend to have a little more severe symptoms affecting the nervous system. So that can be balance issues, that can be blood pressure issues, that can be how cognitively intact you are, that can be, altered mental status issues. All of those things can happen. Sleep disorders can also happen. For this one in particular, it's the rapid eye movement sleep behavior disorder. So a lot of the times these people also don't get that deep sleep that we need to process, and they can move around a lot in their sleep. So think of with a Parkinson's patient, you might get a story of, they become violent in their sleep. They might punch their partner or caregiver or something of that sort. That tends to happen also in this sort of dementia. Changes in mental status, like I mentioned, or seizure-like activities you might see as well. Visual hallucinations and delusions are very, very common with dementia with Lewy bodies. That's why in the Alzheimer's disease dementia, I pointed out that hallucinations are very rare, except in the very, very, very late stages. With dementia with Lewy bodies, it's early. It is not going to be something that, just at the end you'll see. There's something called Capgras Syndrome that is a very commonly seen with dementia with Lewy bodies. And basically, it's a type of delusional disorder. So you usually think like a family member or someone has been replaced by either another person or thing, depending on who the person, how the person is thinking. Frequent fluctuations in attention. So, they may be going from able to focus to completely off the wall, or completely just their mental status has completely gone down. And then the next thing you know, they're fine again. So there can be a lot of that fluctuation that happens. And then repeated falls, gait problems in the bradykinesia, that's very similar to like the Parkinson's disease patient. And then severe sensitivity to medications that affect the nervous system. So when you have dementia with Lewy bodies, we always have to be careful with how we're treating these patients, because if we give them certain types of medicines, we can actually make them worse. Okay. So let's talk a little bit really quick about the evaluation. Clinical history. So we're looking for, are you having hallucinations? Are you having any delusions? How quickly did your symptoms come on? Was it motor stuff first? How quickly after the motor stuff started that you started to have some memory problems? That is going to be really important history for us to kind of have a better picture of what it is that we're dealing with. Also, when we do a physical exam, we're looking for that rigidity. We're looking for that cogwheel motion. We're looking for a tremor. We're looking for these symptoms because it's very similar to Parkinson's disease. Just that you have more of these Lewy bodies that have developed, and now you're having very significant memory problems in addition to the motor stuff. MRI of the brain or CT of the brain that you can do. You're looking to rule out other things. You're also looking to look at the brain volume tissue. And then the FDG PET and the perfusion spec I've talked about before, same thing as before. We're looking at the brain metabolic activity and we're looking at perfusion. We want to make sure blood's getting up there. And when the blood gets there, what is the brain doing with it? Also, the cognitive assessments, similar to the ones before. So it's not going to be very different in that sense. Treatment-wise, the big one I have here in the first is that we try to avoid certain antipsychotic medications, in particular, first generation. So the big one that we think about here is going to be Haldol. So anyone that's been to the hospital with a patient or a loved one that is, delirious, maybe agitated. The first thing that's a go-to tends to be Haldol. So this is where, for all caregivers, I always have this conversation about advocating for your loved one. If you walk in there and your loved one is, agitated, pulling everything out, yelling at people, throwing things, which is very possible with this disease, and they're like, oh, we have to give them some medicine, you better say to them, please do not give them Haldol. Okay. Right. Because if you do, and if you don't, and they do give them Haldol, they will get worse. And the situation will not get any better. And potentially they might get really, really sick. So this is where, it's very important for you to bring that sort of thing up. My mom, my dad, my sister, my brother, my husband, my wife, they have dementia with Lewy body. Please do not give them Haldol. Okay. Acetylcholine esterase inhibitors can also help with symptoms. The ones that they have seen to be somewhat beneficial are donepezil and galantamine. So just know the other ones not as beneficial in this particular patient population, but this might give a little bit of relief of some of those memory symptoms. Not disease modifying, only symptom helping. Stimulant medications can also help with some of that daytime sleepiness from the rapid eye movement sleeping disorder. And usually these are the treatments that we have right now. There is unfortunately no disease modifying medication to help with Lewy bodies. I do want to say though, medications right now in the investigational world or clinical trials world are very much so focused on trying to help with inflammation. And some of them are looking at Lewy bodies, but not particular Lewy bodies associated with dementia with Lewy bodies. Some of those might be beneficial in these types of patients, but they haven't put it for that indication yet. So just know that maybe in the coming years, you might see that they might say, okay, we found that this does help in patients with Alzheimer's or with Parkinson's. Maybe we can try this in a patient that has dementia with Lewy bodies. Frontotemporal dementia is what we're going to talk about next. This one, the proteins are, or the cause of them is deposition of proteins in the tau tangles. Remember, those are the ones that are like the hair-like proteins that you see in the cell that stops nutrients from coming in, prevents the message from going out. There also is the DNA binding protein. If you really want to look into it, it is called the transactive response DNA binding protein 43 inclusions. Well, that's but I think DNA binding protein is probably easier to keep in mind. But that's what basically is depositing in the brain, causing the damage in this particular type of dementia. Now, there are two variants of frontotemporal dementia. There is the behavioral variant, and then there is the language variant. For the behavioral variant, we usually see it in patients that are younger than 65, at least the onset of it. And then it has a shorter duration than Alzheimer's. So what that is basically telling you is from the onset to the time a patient progresses is probably going to be a lot shorter. And when you see that shorter onset, that onset at a younger age than 65 plus, things are moving along more rapidly. This is going to be one of those ones you want to keep in mind. Okay. The risk factors for this particular variant is going to be male predominance. It's more in males for this particular one than females. Females are very much so connected with the Alzheimer's disease, whereas males, you'll see more the behavioral frontotemporal. Autosomal dominant gene, meaning you only need to get one from mom or dad. That's about 10% of the population. And then family history of dementia is in 30 to 40% of the population. So that's where the medical history aspect is going to be also important. You come and tell me, hey, I've had a family member that had dementia. They don't really know exactly what type, but they were having a lot of memory symptoms and maybe some behavioral symptoms. I'm going to keep this on my radar. Now, I'm just going to talk a little bit more specifically about the behavioral variant of the frontotemporal dementia. Usually the patients will have some sort of alteration in their personality or their behavior, right? They also will pretty much deny that they're having really any impairment. But there will be some sort of significant function impairment and poor insight or comprehension of what's happening to them. And so everyone around is saying, something's wrong. But the person themselves are like, I'm fine. Nothing is wrong. They also tend to, in this population, develop obsessive-compulsive behaviors. So that is another thing you can look out for. And they tend to become what we call cold. So they don't really have much sympathy. They don't really have much empathy of anything around them, right? So that's why people tend to say they're very cold people. Also changes in food habits. They can have some bizarre food choices, or it can be where they're just, eating everything in sight. It's just like very gluttonous eating. They might also have, some very interesting food choices in the sense that maybe they want to eat dirt, maybe they want to eat, shavings of things. So that's also something we keep in mind. Muscle wasting is something that does happen because this is going to also affect some of the motor nerve cells and cause damage to those cells. So you might see that instead of it being like, slow movements, rigidity, they start to lose their muscle mass because you can't stimulate the muscle like you should. And you tend to see these patients will have what they call muscle fasciculations, meaning the muscle is like spasming, but it's little tiny spasms, right? It's not like a Charlie horse, unless it's affecting a large muscle. It's usually going to be all these little tiny muscles, right? But your muscle mass overall will start to decline. These patients, early diagnosis can be suspected when you are noticing a functional impairment, but their memory testing is still pretty normal. But for some reason, they're having a lot of difficulties with either their day-to-day activities, activities of daily living, processing of things. But at the same time, you do a memory test and it's pretty much normal. So it doesn't match up.
Are you talking gross motor?
With behavioral variant frontotemporal dementia, the evaluation is pretty much similar to the others. MRI of the brain, CT of the brain. We really want to rule out any structural lesions for this one, especially in the frontal area, because that can be triggering some of these symptoms. The FDG PET, like I talked about before, the perfusion SPECT scan, like I've spoken about before. Also CSF, the cerebrospinal fluid. We can remove that fluid in order to identify the tau tangles. Cognitive assessments with a neuropsychologist, we tend to recommend for these types of patients because it's such a behavioral change and a personality change. So they tend to be able to evaluate the patient a little bit better in that sense. Treatment-wise, just really going to be symptomatic treatment, and that can be for the memory. That can also be for the behavioral changes. So there is no disease modifying treatment at this time. Okay. And symptomatic treatment with memory parts are going to be like donepezil, your galantamine, rivastigmine, so on and so forth. For behavioral, it'll be your antidepressants. If you're having agitation, they might consider some of the antipsychotic medications as well. Okay. For the language variant frontotemporal dementia, this is going to be a lot of the times the patients that are having more progressive aphasias. So if you have a stroke and you have aphasia or difficulty speaking, that's a different story. But if it's something that's just developing over time and, you're evaluating and it's not that you're having multiple strokes or anything of that sort, we need to evaluate, is there a language variant frontotemporal dementia happening? So in this particular population, language, of course, is going to be the principal cognitive impairment that we're looking at. And it's going to be the cause of their functional impairment because they can't speak, they can't communicate. So then they start to have decline in other areas of what they can do. The categories can be fluent, which means that comprehension is the issue there. They can talk to you for days, but they won't make any sense, right? Because they can't comprehend what you're asking or telling them. They're just spewing back out what they think they should be saying. Non-fluent people, they can understand you. they just, of course, now can't talk to you the way that they need to. So either or is frustrating. But yeah. So they're similar to behavioral variant when it comes to the risk factors. So the only thing that might be a little bit different is the male predominance.
Mm-hmm.
Onset is typically, once again, at a younger age, so younger than 65. Alzheimer's disease is usually 65 and above, with a majority, at least 30% of cases, or 32%, 85 and above. And then usually it's around the same as the behavioral variant. Same evaluations, nothing changes there. And the treatment symptoms, we treat the symptoms, and we also refer to speech therapy. So once again, the symptoms would be the memory symptoms, which we can give the symptomatic treatments like donepezil, rivastigmine, galantamine. And then if there are any mood components that develop because we're having difficulty with how we speak or how we comprehend, then we can definitely do that. And then the speech therapy hopefully will help with usually the non-fluent more so than the fluent. You may also consider some assistive language devices. That's going to be for patients who are more on the non-fluent side. So now we're going to move on to what we call the non-neurodegenerative dementias, right? So what that basically means, it's not something that's depositing in the brain per se that is causing the dementia. So this is something else that's happening to our brain that's leading to us having difficulty with cognition. So with vascular dementia, the cause is cerebrovascular disease. So over here, if I can get there we go. What I'm showing you is a nice normal artery or vessel. Blood is flowing beautifully. There isn't anything built up in the walls. It looks nice and healthy. Slowly, we start to accumulate cholesterol here. And that's the nice yellow stuff here. And as that accumulates, you see it starts to narrow the passageway for the blood. And as they accumulate more and more, we have even more narrowing. Now, there's two things that can happen here. It gets so narrow that the blood can't flow well, or this, what we call plaque, will rupture, completely close off this area, and we'll have something like a stroke. Or a blood clot will happen because all of these little cells just accumulate because they can't move, or something comes from our heart up to our brain and we have a stroke. Okay. And whether that be a large stroke or a small stroke will kind of depend on what symptoms you're going to have. So if it's a large, massive stroke with extensive damage to an area, then of course your symptoms might be a little more rapid onset, because now all of that tissue is damaged and maybe it doesn't recover well. If it's many little tiny strokes, it might take a lot longer of time for your symptoms to develop, but you'll have where all those little tiny areas will then come get closer and closer and closer together to where it forms a larger area. And that's when we start to see more of the cognitive issues. Okay. Right. Usually the onset is going to be in the older population greater than 65, because usually if we are having some clogging happening, it's going to take a while. And usually it's going to be in the smaller vessels, which means you're going to have little bits and areas that die off. It's only when many of those little tiny bits and areas, they're all over your brain, that you start to really develop symptoms. The risk factors: age, systemic vascular disease. So if you have coronary artery disease, you've had a heart attack, you've had what they call a CABG, where they have to replace vessels in your heart. You have peripheral vascular disease. You have carotid vascular disease. That is pretty much letting you know if it's happening everywhere else, it can also be happening in your brain. Yeah. History of stroke lets you know already, hey, we've had some clogging or we've had something happen in the brain that there's not the blood flow that we need it to be. So specific symptoms of vascular dementia, usually it's going to be, gait abnormality, repeated falls, because it's happening, so many different areas of the brain is being damaged that your balance tends to get a little bit off. Now, if let's say you had a larger stroke in what we call the cerebellum, then balance will be maybe one of the first things that you see with repeated falls. Emotional excitability. So this is something called a pseudobulbar effect. A lot of the times we see this after someone's had a larger stroke.
Right.
But with patients who have had multiple little tiny strokes, and that's what's causing the dementia, you'll have the same similar effect. And what that is, you can go from excessively crying to excessively laughing. Just the behavior is not appropriate for what's happening in the environment or the conversation or whatever it may be. So it's like you go from one extreme to the next. And sometimes they can be like just quiet and normal, but then they'll start laughing hysterically, and then all of a sudden they're bawling. And so, that's really what that is. Also pronounced apathy. So over time, they kind of just, they don't care, neither here nor there. They're just, sure, whatever. Yeah, I don't have a feeling of either or. And severe slowing of cognition, obviously. So the major signs when you're more thinking of vascular dementia, so your loved one has memory problems, but they're also having some gait impairment, and it doesn't look like Parkinson's, right? They're not doing the shuffling gait business. They're not stooped over. They're not what you're telling me I should be seeing in the other one. And they're not also doing the wide base walk. And they're having these emotional outbursts, and you may be having some falls. Okay. If I see those types of things, then I may be thinking more of a vascular dementia picture. Evaluation. I feel like a broken record telling you guys this, but MRI of your brain, cognitive assessments, and gait assessments. These are the big things that we do for vascular. And then treatment-wise, acetylcholine esterase inhibitors. Once again, donepezil, galantamine, rivastigmine, memantine. These are more for your symptomatic relief of memory difficulty. And then aggressive treatment of your vascular risk factors. If you have heart disease or coronary artery disease, we want to make sure you're treating your blood pressure, you're on a statin, and you're on a healthy diet, you're exercising, because we want to eliminate as many of those risk factors as we possibly can. If you have diabetes, you're controlling your diabetes. Now we'll move on to the next non-neurodegenerative dementia, which is called normal pressure hydrocephalus, or NPH for short. Not fun to say normal pressure hydrocephalus all the time. So you might hear me referred as NPH. So basically what happens here is you have excess fluid in the brain, leading to disruption or damage of the brain tissue. So that excess fluid can be because your normal draining system in your brain is blocked, or it can be that you've had, strokes over the years and you've lost a lot of brain mass. It can be that just you were born that way, and it's just that your ventricles are bigger. And over time, as that fluid is not flowing like it should, or your brain interprets, hey, this is a lot more fluid than I need, it pushes up against that brain tissue. And as it pushes long enough, it causes almost like a bruise and then damage. If anyone in like the medical or nursing world, they call pressure ulcers. Think of it kind of like that. It's like creating a pressure ulcer on the brain tissue because the fluid is just so excess. Onset is usually going to be for this type in the 60s or 70s. Can definitely be younger if it's more of a congenital issue. Risk factors can be any type of brain disorder that affects the flow in the brain. That can be a tumor, that can be a head injury, that can be if there's a hemorrhage from a stroke or trauma. It can be an infection that caused scarring in the flowing of the tracts that let the fluid come out and go in. And it can be inflammation, right? Because inflammation can close off once again or affect the way in which the fluid can flow out. Cerebrovascular disease, I mentioned strokes, that can affect how much fluid is there and how much brain tissue is there. It may not be a big massive strokes. It may not be strokes all over the brain, but maybe in one area a person had a stroke. Now that brain tissue gets softened and it kind of scars up and it's no longer the way that it should be, and we lose that tissue. Now this one ventricle is bigger than the rest. And now we have excess fluid that's forming, and then that's only going to flow around the brain. So now everybody is going to start doing this. And there's different types of normal pressure hydrocephalus. There's communicating and non-communicating, but I'm not going to get into that complication because that's a longer topic. Also, we can see it in diseases that are increasing, the size of the ventricles of the brain. So specific symptoms that's really, really true to NPH type patients that have dementia is going to be bladder incontinence. They might have more mild cognitive impairment, but because they have something affecting their cognitive function, and they're now having, their independence kind of altered, this is why they start to fall into the dementia realm, because they can't function as independently since they're depending on other people to help them. So mild cognitive impairment is typically what we see, but that can progress. And then repeated falls and pronounced gait changes. So like when we think of Parkinson's, we always think of shuffling gait, stoop posture. When we think of NPH, we need to think of more that wide base gait with short step length. So it's kind of shuffling, but it's more, their feet are wider apart. We also see with them some hesitation when they're starting to ambulate. Now we can see that also with some Parkinson's patients when we do the up down test, sit stand, and then when they need to turn, we see some hesitation there. But these particular patients just starting to walk in general, there's some hesitation that happens. So if I see a dementia patient or a patient that's having memory issues, and they're also having bladder incontinence, and they're telling me, hey, I'm falling a lot, I'm having some difficulties with my balance, and I see them walk and they're doing a wide base step, then this would be more what I would be looking into. Evaluation, once again, an MRI of your brain, a CT of the brain, because we really want to look at those ventricles. We want to see, are those ventricles bigger than they should be? And if that is the case, then definitely that's where we sit down and we say, okay, what is causing the ventricle to be bigger? That's one thing we need to rule out. And two, is it because the ventricles are bigger that it's causing the loss of brain tissue? Or do we need to rule out something else? We always keep that in mind. Okay. Lumbar puncture, what that is where they place the needle into your back and they're going to pull off fluid. And the fluid is called CSF. If they're able to pull off 30 to 50 cc's of fluid from you, and then all of a sudden within an hour, your gait is better, your cognition is better, and you just feel better, then that lets me know that this volume this volume removal can indicate there's too much fluid up here that's causing some of your symptoms. We also look at things like opening pressure that lets us know, is there a high volume of fluid? Cognitive assessments, just like the others, if we're going to be thinking about dementia, we have to assess, well, what cognitive function is affected, right? Is it memory? Is it language? Is it your executive functions? We need to kind of figure that out. And then gait evaluation, because we're looking for the wide base step. And then treatment wise, lumbar drainages. So we just do lumbar punctures. They can do it whenever their symptoms get worse. They go to their doctor or neurologist. The neurologist drains the fluid off. They usually evaluate within an hour again, see how they're doing. And then, they go about their lives and they come back when the symptoms start to worsen again. Now, it might get to the point where it's either, hey, we're doing this too often. It's, you're coming back in 2 days, 3 days, a week, or whatever it may be, or they're not able to tolerate any more lumbar punctures, whatever the situation. Then we start to think about things like a shunt. So that's like a permanent thing that's going to drain it from your brain, usually into your abdomen a lot of the times. So your fluid will never build up, and usually you do well when it comes to the gait issues, the falling issues, as well as like the bladder incontinence issues and those sorts of things. And then we have what we call chronic traumatic encephalopathy. This also is a type of dementia, because over time, if you have repeated trauma to your brain, now the big one we think of are boxers. But also we have MMA and all the fighting ones now, and these other types of we'll say recreational entertainment that happens. And with these particular ones, over time, that repeated trauma causes damage and atrophy. Typically, they get hit in the front or the side. So it causes atrophy of those particular lobes. And as with all of the other dementias, when you start to lose brain tissue, we start to have a problem, right? The onset of this is usually going to be in your 60s or 70s. It's usually years and years of trauma to these areas. The symptoms, usually the patient's going to complain of headaches. They're going to say, hey, I've been having headaches for a long time that I've been treating. And they're going to have behavioral changes. These people usually are a little more irritable, a little more impulsive, emotional outbursts of aggression or agitation, also depression and apathy. Also, they have some slowing of their cognitive function, and it's usually not a rapid thing. It's usually over time. So if you were to have someone come in and say, hey, I'm slowly declining and I'm having these behavioral changes, and then you're like, oh, okay, if you have a history of headaches, and they'll be like, yes, what did you do for a living? What was your profession? And if they say, oh, I was, a boxer for 30 years, then this would be higher on my list than me saying, oh, maybe it's dementia with Lewy body, or maybe it's Alzheimer's dementia. So that's where that medical history comes in, and it's very important. They also have very disorganized thought processing, right? It's kind of a little more tangential. It's, they can't follow through the reasoning of something. And then they might have some Parkinsonian symptoms, which is the slowing of all the body movements and the gait changes as well. And that comes from the damage that happens. Evaluation-wise, we're talking MRI again. We're going to be looking for just, softening of brain tissue, extensive brain tissue damage, concussion changes, those sorts of things are what we're really looking for. And then the medical history that I talked about. Now, treatment-wise, we treat the symptoms. If you're having some cognitive issues and memory issues, we're going to treat that. If you're having behavioral issues, we're going to treat that. If you're having headaches, we're going to treat that. If you're having some real significant movement problems, we're going to have, physical therapy and those sorts of things. There is some possible benefit with them utilizing the memory medications. I always like to just make sure I put that there. In chronic traumatic encephalopathy, it's not like an overwhelming bit of evidence that shows you give them donepezil and it's going to be life-changing, but at least you can try it, and they might have some improvement in some of the cognitive issues that they're having. Now, lastly, we're going to talk about the rapidly progressive dementias. And this is a night and day type of situation. Your loved one was fine a week ago. Now, all of a sudden, something is off. The most common is the prion disease, Creutzfeldt-Jakob disease. That can be within a few days, you go from being fine to being delirious, can't take care of yourself, can't process anything, you're not there. There's also perineoplastic syndromes. These are, let's say you have a cancer somewhere in the body. And how that cancer is influencing the way that your body is functioning in your systems. You can have some cognitive impairment that way. Autoimmune and inflammatory encephalopathies, so lupus and Hashimoto's. You can also, MS, multiple sclerosis is another one. Granulomatous diseases like sarcoidosis, we usually think of that in the lungs, but it can happen also in our brain and the CNS system. Neurosyphilis, also there's vasculitis. So all those little vessels in your brain get inflamed and angry and they cause infection. HIV and herpes are two of the biggest ones that we usually look for. And we think of meningitis from a bacterial infection or other or a viral meningitis. Toxicity such as alcohol, drugs, and heavy metals. can also cause a very rapid onset of delirium and dementia. So the symptoms, the big thing, a week ago, mom, dad, brother, sister, wife, husband, they were doing fine. Everything was good. A week later, they don't know what's going on. They can't do anything for themselves. I don't know what happened. That's usually the story that you're going to get. Right. And then they're going to do an extensive systemic workup, because now we've got to figure out, why did this person going from being fine to not being okay, right? We also will do an MRI. We're evaluating, once again, what's happening in the brain. CSF, we're really evaluating, well, is this a tau thing? Is this a beta amyloid? Is this infection? Is it a viral infection, a bacterial infection? Do I see cancer cells in their fluid? What's happening? And then an EEG is used for seizures. So we're evaluating, maybe they're having seizures, and that's why the brain's not functioning well. So that's another one. Now, if let's say it's a seizure type disorder, we don't necessarily have to have an EEG to recognize that, but it can definitely help us. EEGs, we tend to do a lot with Creutzfeldt-Jacobs disease. So when we're evaluating the prion, we can utilize an EEG to kind of evaluate for seizures and the activity in the brain. Treatment-wise, it's treating what that underlying disease is. And by treating the disease, the hope is that you will help the patient have better cognitive function. And that's all of them.
Wow.
I hope it was helpful and informative and not too complicated.
No.
And here, let me just stop sharing this part. Perfect. All right.
Terrific. I thank you so very much. If you would,
I'm sorry, give me one second. For some reason, I can't hear you. Let's see now.
That's okay.
Okay, there we go. I can hear you now.
Okay, cool. If you would like to, make me the host again.
Let's see.
That's cool. And Jody, you joined us. And
yes.
I've
been here. Yes, I've been here. Thank you.
Let's see. More. Make host. Found it.
So Jody, talk to me a little bit about how your why you joined us today.
I joined you guys because I wanted to learn more. Even though I talk to families a lot about the different diseases, I really wanted to know more in depth, really how I can easily explain to families what their loved one's going through. And I know Dr. Agard does a very good job of explaining that at a way we can really understand it, and it's not above our heads.
Right. And Jody, what organizations are you with?
I'm with Clincloud, and I work with Dr. Agard, and I'm also with the Alzheimer's and Dementia Resource Center.
And
here.
Go ahead. I'm just, and like the Reader's Digest version of what that organization does.
Well, of what that is ADRC. We cover Orange and Seminole County. However, because I know you guys are in Brevard County, we have Zoom classes that anyone can join. So anyone can join in, anyone, if they're needing a care coaching, calling us to discuss how they can care for their loved ones at home, because we primarily work with the caregivers caring for their loved ones at home. They can do that. We also offer support groups online. We now have a brand new Spanish support group that we're offering online as well. It's Zoom. Yes, it's going to begin April 1st. Alexandra, who I work with here at ADRC, she is actually going to be heading up that group. We also have Savvy Caregiver, which are for caregivers. It's a 6-week series that we do, along with, what else was I going to tell you? The Brain Bank, and that if someone would like to donate their loved one's brain to be studied for science, they can do that. It has to be done well ahead in advance. It takes 6 to 8 weeks to enroll someone. The brought down version of it is that you'll enroll and then you will receive a complete pathology report that is sent to you, telling you what the person's brain had, whether it was 1 dementia, 5 dementias, exactly what was going on. And Alexandra can go more in depth with family members to explain that to them. And then I work with Clincloud, which is clinical research. However, it is fantastic. People can have free memory screens done here. We can do different studies. We have some that are with medications, some that are without medications, if they would like. Upon enrolling in studies, we have free mental health counseling that we can help with. So we can do all studies in Spanish as well, which is something very good. I'm very excited about that. Yes. And we also have support groups with Clincloud as well that are offered on Saturdays, actually. So if working caregivers can't get to our support groups, they can go to Clincloud support groups.
Fabulous.
Okay.
So anybody that would like more information on any of these things, the ADRC or the Brain Bank or Clincloud, feel free. If you guys would like to quick give a contact information, how can they get Jody, how can they get a hold of, how can folks get a hold of you?
They can get a hold of us at ADRC by calling 407-436-7750. Or if they would like to call Clincloud, they may call 407-636-4031. And Beth, I wanted to also mention with Clincloud, anyone who would like to participate in any of the studies, we also provide free transportation to and from the clinic. So we will pick up in Brevard County, we can transport. So that's another option on the Clincloud side of things for people.
Fabulous.
Okay.
I thank you both so very much for coming on to our caregiver conversations today and really deep diving into an area that is scary, and we still don't know as much as we would love to be able to know, but it's really impacting so many people as we're all aging. So I really appreciate it today, and I hope people have a fabulous weekend. And Jody, I think I'm going to go visit wherever you are right now with that beautiful background.
Oh, thank you. I'm always at the beach.
Thanks again, ladies. We'll talk.
Thank you so much.
Okay.
Have a good one, okay?
Thank you. Bye-bye.
Bye.